Hope everybody's having a good day. My name is Michael Lim, currently interventional cardiologist and the director of the Center for Comprehensive Cardiovascular Care at St. Louis University, and privileged to be part of the first ever virtual Scottsdale Interventional Forum, this time from my office in St. Louis. So thank you for Dr. Reisig for giving me this opportunity to talk about the alphabet soup of coronary physiology, and especially how to apply it in my cath lab and hopefully as you, the audience, in your cath lab. As part of my disclosures, in the past 12 months, I've been in relationships and consulting and speaking for Assist Medical, Boston Scientific, and OpSense. With respect to the alphabet soup of coronary physiology, I thought that I would try to make this real and talk to you about a case. So this is a 62-year-old woman who came in to see us. She has hypertension for a long time and has been having some progressive dyspnea on exertion, but she doesn't really think much of this. She's been kind of dealing with this for years. So we got an echo, and she had a normal EF, and she had no valvular heart disease. EKG shows normal sinus rhythm with LVH consistent with her hypertension and no prior infarct. So we underwent a stress test evaluation for her, and she exercised for almost 4.5 to 5 minutes on a Bruce protocol, developed some dyspnea, had some ST segment changes on her EKG that were subtle, but the echo basically showed no real changes that were indicative of stress-induced wall motion changes. She had symptoms that would continue to be persistent and progressive, and we got a CT angiogram, and this was stopped because the coronary calcium score was greater than 800, and so we ended up doing a heart catheterization on her. Here's some of her calcification, as you see, which is not subtle. So the heart catheterization then ends up showing that she has, an intermediate lesion in a pretty significant OM branch there, and intermediate lesion in the proximal LAD with some calcification in the proximal vessels, as was confirmed in the CTA. When we look over to the right side of things, she also has not really significant lesions from a high-grade standpoint within the right coronary artery, but again, calcified. And so we're left with a concept of, well, we have progressive symptoms of dyspnea and some ST changes on a Bruce protocol, but calcium and no high-grade lesions. And so to try to figure out how to best take care of this lady, I think this is the principal reason for needing some sort of coronary physiology. And so when you put a guide catheter in the right coronary artery and you put a pressure wire in the distal right coronary artery, you instantly can see a resting ratio or a resting PDPA ratio of 0.68. In the LAD, if you move around and change the guide catheter around and look at the LAD, we can also do pressure evaluation in here. And this is a different evaluation from a physiologic media standpoint where contrast FFR, so the injection of contrast and taking that picture I just showed you, the FFR drops to 0.83, and this is just with contrast. And we give adenosine down the LAD, the FFR goes to 0.74, and this is obviously true FFR with adenosine-induced, IV adenosine-induced gradient of 0.74. And then if you change the wire around and you go into the OM, you get a resting PDPA ratio of 0.81. So in terms of this patient, I've given you the alphabet soup. I've showed you resting PDPA, I've showed you contrast FFR, and I've showed you adenosine FFR. I don't have capability of doing IFR in my cath lab, but certainly you could have demonstrated similar capabilities with IFR. And so this is the alphabet soup. To do this, some people would argue, well, this takes a lot of time, but if you look at the actual logs here, so the diagnostic angiogram took 14 minutes in this patient, and the coronary physiology took an additional 22 minutes. And in that, you see a calcified proximal mid and proximal LAD with an FFR of 0.74, showing significant lesions in the LAD, calcified lesions in the circ OM system with a resting PDPA ratio of 0.81. as well as a calcified lesion in the right coronary artery with a PDPA resting ratio of 0.68. So we have significant physiologic three-vessel coronary artery disease, which now I'm more certain is attributed to her shortness of breath with exertion. And so in terms of how to manage this patient, I don't know how I would have managed this patient for certain without the indices obtained, but now with certainty, I can say she has three-vessel coronary disease, and revascularization should improve her symptoms as well as her long-term outlook. So in physiologic indices in 2020, we have the hyperemic index of FFR. All systems are allowed and able to do this. You can give IV adenosine, you can give intracoronary adenosine. The FFR ratio of 0.80 as the cut point in terms of determining ischemic versus non-ischemic continues to hold the test of time. A submaximal hyperemic ratio, which I showed you, is contrast FFR. Contrast does not provide total hyperemia, but does provide some hyperemia, and a 0.83 cut point as the difference between ischemic and non-ischemic is something that you can use. And then the newer ratios, which currently exist, the non-hyperemic pressure ratios, whether we use a whole cycle ratio, which is PDPA, which I showed you in this case, and that best cut point is 0.91, or the diastolic portion of the waveform or subcycle indices, whether it's IFR, which is proprietary, or DFR or RFR or DPR, all proprietary, having the cut point of about 0.89. All of these can be used in your lab with a pressure wire to look at the ischemic potential of a given lesion. FFR has obviously been tested, multiple studies, DEFER being the longest one, showing 15-year results and saying that it's safe to medically treat non-physiologic significant lesions. FAME showing 5-year results, FAME 1 showing that ischemic FFR and direct stenting is better than angiographic only stenting approach. And then the FAME 2 study and 5-year results showing that ischemia is better treated with revascularization than with medical therapy alone. If we look at the non-hyperemic pressure ratios, the best long-term data we have is in the IFR studies, whether it's in the individual studies with defined flare or Sweetheart or the combined, in which the operators and the investigators combine these, showing that IFR as an assessment of ischemia was non-inferior to FFR assessment. It gives you great sense of positivity that physiologic indices using to guide patient decision-making in the cath lab can be used. And so take-home points, whether you want to use my patient and the alphabet soup of physiology will be measured for her, or you want to use the data that's supported here, or as I think, the combination of the data. Look, we have FFR and we have non-hyperemic pressure ratios. They have different strengths, they have different weaknesses, and they're compared and contrasted in this table. But in general, it's best to use physiology right now in terms of guiding best revascularization versus non-revascularization and medical therapy alone decision-making in the cath lab. And in the case of the patient I showed you, we ended up offering her a 3-vessel bypass operation, which was successful with a lima and 2 other grafts. And in such, a year and a half after her operation right now, she feels like she should have had this done 3 or 4 years ago, because she's doing things that she just hasn't done in the past 5 to 7 years. And so the alphabet soup and how to use it in your lab, I think the bottom line is all you have to do is have a pressure wire and the will to use it. And if you use it and the cut points that we showed, you're going to provide the best possible outcomes for every patient that you take care of. I hope this was somewhat helpful in terms of trying to sort through the different things you can do in the cath lab with physiology. And I wish all of you the best of luck in these times that COVID and 2020 has brought us. Thank you very much.